Cardiology. Condition: hypertension. Background: may be primary, no specific cause, or secondary. Causality may be related to an endocrinologic, cardiovascular, or renal disorder. Optimal BP, SBP and LT 120 mmHg and DBP and LT 80 mmHg. Overall BP goal is and LT 130/90 mmHg. Clinical features. Important elements of the history include onset, duration, previous measurements, current and previous medications, risk factors, family and personal history of CKD, HTN, DM, dyslipidemia, stroke, and premature CVD, modifiable lifestyle factors including smoking, diet, weight control, obesity, exercise, recreational drug use and alcohol intake, personal, psychosocial, and environmental factors, and depression, social isolation, and quality of social support, history and symptoms of end organ damage and CVD, and symptoms related to secondary hypertension. PE focuses on evaluating for signs of secondary hypertension and/or organ damage, pulse, rate, rhythm, and character. JVP, evidence of cardiac enlargement, heart failure, and arterial disease, palpation for enlarged kidneys, abnormalities of the optic fundi, abnormalities of the endocrine system, obesity. Diagnosis: at least 2 BP elevations 1 week apart or sooner if with very high BP. Clinic BP level is used for risk stratification. 24H ambulatory BP gives the most accurate and comprehensive information and is used if the diagnosis is in question, example white coat hypertension. Home BP monitoring is best for medication changes, example dose adjustment, addition of another medication. Initial investigations for all patients include urine dipstick for blood, followed by microscopy if abnormal, albuminuria status usually with urine albumin/creatinine ratio, normal in males and LT 2.5, females and LT 3.5, microalbuminuria in males 2.5 to 25, females 3.5 to 35, macroalbuminuria for higher values, fasting glucose, fasting cholesterol, TC, LDL, HDL, TAG, renal function, urea, electrolytes, eGFR, hemoglobin, and/or hematocrit, ECG. Additional investigations are tailored based on the initial findings, history, PE, diagnostics. Management. Risk stratify patients using the CVD risk calculator or CVD risk chart, sample. Chart will be presented in the live lecture. Take note of the eligibility criteria. Ineligible patients may be stratified using other parameters, example based on family history, HSCRP level and GT3, ethnicity, comorbidities. Low to intermediate risk, low risk equals and LT 10%, intermediate risk equals and LT 15%, patients may be managed conservatively, non-pharmacologic, at least initially. Intermediate patients may likewise be re-stratified using ancillary tests or essential information in the history, example ethnicity, family history of premature CVD, to either low or high risk and managed accordingly. Non-pharmacologic management includes physical activity, 152 minutes of moderate intensity exercises most days of the week but not more than 2 days apart with resistance exercises, weight control, normal BMI, diet low in fat, 20 to 35% of energy intake, and salt, and LT6G/D4, primary prevention, and LT4G/day for secondary prevention, smoking, cessation, and moderation of alcohol consumption, 1 to 2 SD/day, high risk, and GT 15%, patients require pharmacologic treatment, i.e., anti-hypertensive medications with or without, but usually with a statin for primary prevention. ASA is given for secondary prevention except for colorectal cancer prevention. Any of the first-line medications, i.e., thiazide diuretics, calcium channel blockers, ACEI, or ARB, may be used. Start with one drug at the lowest dose, then follow up after 2 to 3 months. If control is suboptimal, add another medication from a different drug class. Instead of up-titrating the dose of the current drug, if control remains suboptimal, increase the dose of one drug and then the other until target BP is achieved. A patient on 3 antihypertensive drugs who remain to have poor BP control must be referred to a specialist for the evaluation of resistant HTN. ACEI/ARB is best for patients with proteinuria. BP target for patients with a history of stroke is lower than the recommendation for other conditions, SBP and LT120. Condition: ischemic heart disease, acute coronary syndrome's background. Ischemic heart disease may be classified as stable angina, chronic symptoms due to a relatively fixed coronary obstruction, or acute coronary syndrome, new or increasing symptoms due to unstable atherosclerotic plaques or endothelial disruption. Myocardial infarction can also be classified as type 1 spontaneous MI, due to acute coronary occlusion, or type 2 MILS, due to imbalance in supply and demand, example coronary vasospasm, arrhythmias, anemia, respiratory failure. Based on ECG findings, ACS may be classified as STEAC/STEMI and NSTEACS, which can be further classified as NSTEMI, elevated cardiac biomarkers, and UA, no elevation in cardiac biomarkers. Dyslipidemia and cigarette smoking are the two strongest risk factors for acute MI. Clinical features. Acute chest pain evaluation should always consider the 6 life-threatening causes: acute MI, aortic dissection, cardiac tamponade, pulmonary embolism, tension pneumothorax, and Boerhaave syndrome. Chest pain due to ACS is typically described as crushing or heavy central chest pain radiating to the arms, neck, back and jaw. Associated symptoms or anginal equivalents include diaphoresis, shortness of breath and nausea. Silent acute MI is more common in females, elderly and diabetics. Diagnosis. ECG should be performed in all patients presenting with angina and undifferentiated chest pain. A normal ECG does not rule out acute MI. A comparison from previous records or from serial monitoring will have a better yield in demonstrating dynamic changes. Troponin is the most specific of the cardiac biomarkers but may be normal during the early phase. CKMB rises earlier but is less specific, and, thus, best performed serially. Management. Initial therapy in the general practice or ambulance. Give oxygen if hypoxemic, and LT 94%. Medications. Aspirin 300 mg orally stat. Glyceryl trinitrate spray 400 to 800 mg sublingually, repeated every 5 minutes if pain persists, up to a total of 3 doses if tolerated, or glyceryl trinitrate tablet 300 to 600 mg sublingually, repeated every 5 minutes if pain persists, up to a total of 3 doses if tolerated. And, for persistent chest pain, fentanyl 25 to 50 mg intravenously, as an initial dose, repeated at 5 to 10 minute intervals, if required to relieve pain, or morphine 2.5 to 5 mg intravenously, as an initial dose, repeated at 5 to 10 minute intervals, if required to relieve pain. Hospital management. Please review acute coronary syndrome guidelines. Once ACS is confirmed, patients are risk stratified. Very high risk, hemodynamically unstable, acute heart failure, cardiogenic shock with mechanical and electrical complications. High risk, recurrent or persistent ischemia. High risk, rise and/or fall in troponin compatible with MI. Dynamic ST segment and/or T wave changes. Grace score of NGT 140. Intermediate risk. Presence of diabetes mellitus, kidney disease, ejection fraction pound 40%. Previous angioplasty or bypass. Grace score of NGT 109 and LT 140. The aim of STEMI management is reperfusion, PCI or fibrinolysis, while the aim of NSTEMI management is plaque stabilization, medical or revascularization. Admission in the coronary care unit. Management of STEMI. Immediately started on dual antiplatelet and anticoagulant therapy. All patients should receive aspirin 300 mg orally initially, then 100 to 150 mg daily. For patients undergoing PCI, aspirin is given with clopidogrel 600 mg orally initially, then 75 mg daily, or ticagrelor 180 mg orally initially, then 90 mg BD, or prasugrel 60 mg orally initially, then 10 mg daily. For patients undergoing fibrinolysis, aspirin is given with clopidogrel 300 mg orally initially, then 75 mg daily. Reperfusion either by PCI or fibrinolysis is generally recommended within the first 12 hours, but may be considered after this for continuing ischemia, if a viable myocardium remains, and in cardiogenic shock. If available, PCI is preferred over fibrinolysis with a door-to-needle time of 90 minutes. If PCI is not available, fibrinolytic therapy should be given within 30 minutes of hospital arrival. Kindly review the absolute and relative contraindications for fibrinolytic therapy in STEMI. If PCI is not available and fibrinolysis is not an option, the patient should be transferred immediately to a PCI-capable tertiary center. Regimens for fibrinolysis include alteplase, riteplase, or tenecteplase. Regimens for anticoagulation include enoxaparin or unfractionated heparin, in CKD or in patients at high risk of bleeding necessitating rapid reversal. Long-term medications, in addition to antiplatelets, include a statin, a beta blocker, and an ACEI. Management of STEMI. Immediately started on dual antiplatelet and anticoagulant therapy. All patients should receive aspirin 300 mg orally initially, then 100 to 150 mg daily with, unless planning cardiac surgery, clopidogrel 300 to 600 mg orally initially, then 75 mg daily, or ticagrelor 180 mg orally initially, then 90 mg BD, or prasugrel 60 mg orally initially, then 10 mg daily. In patients at very high or high acute risk, anticoagulation is started with dual antiplatelet therapy. Anticoagulants include enoxaparin, dalteparin, unfractionated heparin, and bivalirudin. If there is a contraindication to heparin use or a high bleeding risk procedure is contemplated. Beta blocker therapy is initiated early, unless contraindicated, example atenolol 25 mg orally daily increasing up to 100 mg daily, or metoprolol tartrate 25 mg orally daily increasing UO to 100 mg BD. Glycoprotein IIB/3A inhibitors, e.g., abciximab, tirofibin, may be used if PCI is not readily accessible, especially if with recurrent ischemia. Intermediate risk patients are treated initially with either low-dose aspirin or AP2Y inhibitor. Low-risk patients require further restratification, example stress testing. Stable angina. Background. Angina is stable if there is no change in its pattern over a period of time. Increased epicardial coronary resistance due to atherosclerosis is the major pathophysiology involved, but may be mimicked or aggravated by conditions such as anemia, aortic stenosis, thyrotoxicosis, and hypertrophic cardiomyopathy. Clinical features. Angina is classically described as chest heaviness or tightness lasting for 10 minutes or less and is relieved by rest. Diagnosis. ECG is always the first investigation for suspected cardiac chest pain. Patients with an intermediate to high likelihood of ischemic heart disease with normal ECG is worked up further by stress testing, perfusion studies, or angiogram. Treadmill stress test is ideal for patients with a normal ECG who can exercise. Stress echocardiography, exercise if able or pharmacologic if not, and myocardial perfusion studies, nuclear SPECT perfusion, dobutamine nuclear perfusion, vasodilator nuclear perfusion, PET/CT, are ideal for intermediate risk patients with an abnormal resting/baseline ECG. Coronary angiography is both diagnostic, definitive test, and therapeutic, angioplasty. CAC score may be used in asymptomatic, intermediate risk patients. Management. Optimal lifestyle advice following the SNAP Guide. Pharmacologic treatment of ischemic heart disease and its risk factors. Example: dyslipidemia/atherosclerosis, statin plus aspirin, diabetes mellitus, SGLT2I as an initial add-on to metformin, hypertension, ACEI. Acute anti-anginal medications include glyceryl trinitrate spray 400 mcg sublingually, repeated every 5 minutes up to 3 doses, or glyceryl trinitrate tablet 300 to 600 mcg sublingually, repeated every 5 minutes up to 3 doses. Therapy for angina prevention include a combination of 2 of the following: beta blockers, atenolol, metoprolol tartrate, non-dihydropyridine calcium channel blockers, diltiazem, verapamil, dihydropyridine calcium channel blockers, amlodipine, nifedipine MR, long-acting nitrate, glyceryl trinitrate, isosorbide mononitrate MR, or nicorandil, for refractory angina. Condition: heart failure. Background: diagnosis is based on typical signs and symptoms and investigation findings. The typical trajectory spans 4 stages as presented in the Figure 1. Figure 1. Heart failure trajectory source, think GP. Classified as HFrEF or HFpEF. Poor prognosis with 82% of patients dying within 6 years of diagnosis. HFrEF, LVF and RVF may occur independently, or together as CCF. Risk factors include coronary artery disease, major risk factor, low physical activity, cigarette smoking, overweight, hypertension, diabetes mellitus, valvular heart disease, left ventricular hypertrophy, family history of cardiomyopathy, atrial fibrillation, and obstructive sleep apnea. Targeted screening is performed in the presence of 2 or more risk factors, 1 or more typical signs and symptoms, and over 60 years of age. Clinical features. Dyspnea is the most common symptom. Urgent evaluation is indicated in the presence of orthopnea, paroxysmal nocturnal dyspnea, syncope, ischemic chest pain, tachycardia, bradycardia, hypotension, hypoxemia, gallop rhythm, and heart murmur. Differential diagnoses include pneumonia, chronic obstructive pulmonary disease, pulmonary fibrosis, cirrhosis, renal failure, anemia, and pulmonary embolism. Diagnosis. Echocardiography is the single most important test and will confirm the diagnosis, demonstrate the cardiac structure and function, assess severity, and classify as to HFrEF or HFpEF. Refer to Figure 2. Figure 2. Heart failure classification source, think GP. Other investigations include: electrocardiography may manifest with left bundle branch block, first-degree AV block, left anterior hemi block, nonspecific intraventricular conduction delays, LV hypertrophy, evidence of previous Q-wave MI, sinus tachycardia, atrial fibrillation. Chest X-ray, used to rule out pulmonary causes of dyspnea. Demonstrate pulmonary congestion. Laboratory testing. BNP/proBNP is good in ruling out other causes of dyspnea. Full blood count, anemia confers a poor prognosis. Urea, creatinine, and electrolytes, dilutional hypoatremia, hyperkaliemia from impaired renal function or pharmacologic treatment, hypokaliemia from diuretic use, hypomagnesemia from diuretic use, rising creatinine with worsening heart failure. Liver function, congestive hepatopathy resulting in abnormal liver function tests, elevated bilirubin, hypoalbuminemia. Thyroid function test, both hyperthyroidism and hypothyroidism can cause heart failure. Other investigations used in evaluating the cause of heart failure. Management. Refer to the Non-Pharmacologic Management of Heart Failure podcast. Refer to Figure 3 for HFrEF management algorithm. Figure 3. HFrEF management algorithm source, ThinkGP. Medication that are recommended for all patients with HFrEF include ACEI, beta blockers, and MRA. Medications that are recommended for some patients with HFrEF include ARB, ARNI, diuretics, ivabradine and intravenous iron. Review of medications for HFrEF. Diuretics. Used to optimize fluid balance. For patients with HFrEF, start with a loop diuretic. ACEI. Patients with symptomatic and asymptomatic left ventricular dysfunction should be treated with an ACEI. Initiated first before beta blockers. Dose is doubled every 2 weeks to target dose. UEC is monitored every 1 to 2 weeks. ARB. Alternative to ACEI in intolerant patients. Beta blockers. Euvolemic patients with HFrEF should be treated with one of the following heart failure beta blockers: carvedilol, bisoprolol, metoprolol succinate, nebivolol. Dose is doubled every 2 to 4 weeks with close monitoring of heart rate and blood pressure. Mineralocorticoid receptor antagonist. For patients who remain symptomatic with ACEI and beta blockers. Also recommended for post-STEMI patients who are already receiving therapeutic doses of ACEI, have an F-pound 40%, and have either symptomatic heart failure or diabetes mellitus, who can be monitored for serum potassium and renal function. Dose is titrated every 4 to 8 weeks with close monitoring of UEC. ARNI, sacubitril valsartan. Recommended as a replacement for an ACEI/ARB in patients with F-pound 40% despite maximally tolerated or target doses of ACEI/ARB and a beta blocker, with or without an MRA, should be administered with a 36-hour washout period to prevent angioedema. Dose is doubled every 1 to 4 weeks with dose adjustment based on liver function. Ivabradine. Consider for patients with F-pound 35% and with a sinus rate of superscript 370 BPM despite maximally tolerated or target doses of ACEI and a beta blocker, with or without an MRA. Hydralazine plus nitrate may be considered in patients who are persistently class 2 to 4 despite optimal conventional therapy, particularly dose with low output syndromes, hypertension, or mitral regurgitation. Digoxin, not routinely given. Used only in class 3 or 4 HFrEF on optimal evidence-based therapy to control symptoms and in patients with AF to control the ventricular rate. Target level is 0.5 to 0.8 ng/ml, check levels until steady state is reached, which is approximately 7 to 10 days for most patients, and up to 3 weeks in renally impaired patients. Intravenous iron. Iron studies should be performed in patients with persistent symptoms despite optimal heart failure therapy, deficient. For HFpEF, the principle of treatment is to address the underlying risk factors with particular emphasis on control of blood pressure and volume. To date, no standard medication, except the SGLT2I recently, has been demonstrated to have significant reduction in morbidity and mortality in HFpEF. Condition: carotid artery stenosis. Background: the definition of asymptomatic or symptomatic carotid artery stenosis is based upon the history and physical examination, depending upon whether there are symptoms or signs of carotid territory ischemia. Maximum stenosis is usually at the carotid bulb. Clinical features: it may be associated with amaurosis fugax, TIA, crescendo TIA, stroke in evolution, and cerebral infarction. Diagnosis: there are 3 methods most used to measure stenosis. North American Symptomatic Carotid Endarterectomy Trial, NASIT, measures the residual lumen diameter at the most stenotic portion of the vessel and compares this with the lumen diameter in the normal internal carotid artery distal to the stenosis. A 50% stenosis with the NACIT method is comparable to 5% stenosis for both European carotid surgery trial, ECST, and common carotid, CC, methods. A 70% stenosis with NACIT method is comparable to 82% stenosis for both ECST and CC. ECST measures the lumen diameter at the most stenotic portion of the vessel and compares this with the estimated probable original diameter at the site of maximum stenosis. CC measures the residual lumen diameter at the most stenotic portion of the vessel and compares this with the lumen diameter in the proximal common carotid artery. Cerebral angiography. Previously the gold standard for imaging the carotid arteries. Advantages. Allows the evaluation of the entire carotid artery system, providing information about tandem atherosclerotic disease, plaque morphology, and collateral circulation which may affect management. The presence of associated intracranial atherosclerotic disease identifies a group that is particularly likely to benefit from carotid endarterectomy. Disadvantages. Invasive, high cost, risk of morbidity and mortality, especially with cerebrovascular symptoms, advanced age, diabetes, hypertension, elevated serum creatinine, and peripheral vascular disease. Carotid duplex ultrasound, currently the gold standard in imaging the carotid arteries. Uses B-mode ultrasound imaging and Doppler ultrasound to detect focal increases in blood flow velocity indicative of high-grade carotid stenosis. The peak systolic velocity is the most frequently used measurement to gauge the severity of the stenosis, but the end diastolic velocity, spectral configuration, and the carotid index provide additional information. Advantages. Non-invasive, safe, and relatively inexpensive. May be used as a sole basis in deciding to proceed with revascularization. Disadvantages. The absence of flow in the internal carotid artery may be due to occlusion, but hairline residual lumens can be missed. Tends to overestimate the degree of stenosis. Less precise in determining stenosis and LT 50%, but rarely impacts its clinical utility. May be limited by features such as calcific carotid lesions, tortuous or kinked carotid arteries, and patient body habitus. Transcranial Doppler, TCD. As adjunct to CDUS, TCD examines the major intracerebral arteries through the orbit and at the base of the brain. Often used in conjunction with CDUS to evaluate the hemodynamic significance of ICA stenosis, and it can be used to improve the accuracy of CDUS in identifying surgical carotid disease. Contrast-enhanced ultrasound may be useful for evaluating carotid plaque neovascularization. Helps distinguish complete carotid occlusion from near occlusion and improve lumen visualization in carotid arteries that are technically challenging to study by conventional CDUS. 3D ultrasound improves visualization of vascular anatomy. Advantages compared with traditional ultrasound include the potential for quantitative monitoring of plaque volume changes in all three directions. Management. Carotid endarterectomy, CEA. Indicated in patients with recently symptomatic carotid stenosis of 70 to 99% and a life expectancy of at least 5 years who meet all the following conditions. A surgically accessible carotid lesion. Absence of clinically significant cardiac, pulmonary, or other disease that would greatly increase the risk of anesthesia and surgery. No prior ipsilateral endarterectomy. Low-dose aspirin is recommended for all patients who are having CEA, started prior to surgery and continued for at least 3 months after surgery. Beyond 3 months, continued antiplatelet therapy is indicated for most patients to prevent cardiovascular disease, particularly for those with a history of ischemic stroke or transient ischemic attack of atherothrombotic, lacunar, small vessel occlusive type, or cryptogenic type. For men with recently symptomatic carotid stenosis of 50 to 69% who have a life expectancy of at least 5 years. Other subgroups of patients that may benefit from CEA include older patients, those with hemispheric TIA than those with transient retinal ischemia, those with severe coexisting contralateral carotid stenosis or occlusion. Carotid artery angioplasty and stenting, CA. CA is the standard for endovascular carotid artery intervention. Long-term outcome is the same as CEA except for a higher peri-procedural, 30-day, stroke or death rate with CA. Recommended over CEA for selected patients with recently symptomatic carotid stenosis of 70 to 99% who have any of the following conditions. A carotid lesion that is not suitable for surgical access. Radiation-induced stenosis. Restenosis after endarterectomy. Clinically significant cardiac, pulmonary, or other disease that greatly increases the risk of anesthesia and surgery. Medical management. Reasonable alternative to endarterectomy in patients with asymptomatic carotid disease. Optimal medical therapy, which should include antiplatelet therapy, statin therapy, and risk factor modification, is recommended for all patients with carotid artery stenosis and a TIA or stroke. For patients with symptomatic carotid stenosis that is less than 50%. For women with recently symptomatic carotid stenosis of 50 to 69%. Condition, cardiomyopathies. Cardiomyopathy. Background. Disease of the heart muscle. Exclude cardiac dysfunction that results from other structural heart diseases. A heterogeneous group of diseases of the myocardium associated with mechanical and/or electrical dysfunction that usually but not invariably exhibit inappropriate ventricular hypertrophy or dilatation and are due to a variety of causes that are frequently genetic. General classification. Ischemic cardiomyopathy. Diffuse dysfunction occurring in the presence of multivessel coronary artery disease. Non-ischemic cardiomyopathy. Due to non-ischemic causes. Traditional classification, dilated cardiomyopathy. Hypertrophic cardiomyopathy. Restrictive cardiomyopathy. Clinical features. Early symptoms often related to exertion intolerance. Shortness of breath, early fatigue, usually from inadequate cardiac reserve. Elevation of resting filling pressures. Dyspnea or cough in the supine position. Hallmark of congestion. Peripheral edema. Diagnosis. Thorough history and physical examination to exclude cardiac from non-cardiac causes. Detailed family history of heart failure, cardiomyopathy, skeletal myopathy, conduction disorders and tachyarrhythmias and sudden death. History of alcohol, illicit drugs, chemotherapy or radiation therapy. Assessment of the ability to perform routine and desired activities. Assessment of volume status, orthostatic blood pressure and body mass index. Laboratory evaluation. ECG, chest X-ray, 2DED, electrolytes, fasting blood glucose, kidney function tests, liver function tests, lipid profile, thyroid function tests, iron studies, urinalysis, and creatine kinase. In selected patients, targeted investigations may include titers of infection, viral, bacterial, parasitic, serologies for rheumatologic diseases, and catheterization with coronary angiography in those who are candidates for intervention. Dilated cardiomyopathy. Background. Enlarged left ventricle with decreased systolic function. Systolic failure to diastolic dysfunction. Up to a third may be familial. Mitral regurgitation commonly develops. Clinical features. Signs and symptoms of congestive heart failure, embolization, tachyarrhythmias, atrial fibrillation, ventricular tachycardia. Etiologies. Infective. Viral, Coxsackie, adenovirus, HIV, hepatitis C, parasitic, Chagas disease, toxoplasmosis, trichinolosis, bacterial, diphtheria, brucellosis, chlamydophila, legionella, meningococcus, mycoplasma, psittacosis, salmonellosis, spirochetal, Lyme disease, rickettsial, Q fever, fungal. Consider viral myocarditis in a young adult with progressive dyspnea and weakness for days to weeks after a recent viral syndrome. Initial treatment aims at stabilizing the hemodynamic status and treating heart failure. For patients with subacute presentation, No benefit for glucocorticoid therapy in combination with 4Ig. Chagas disease. Caused by T. cruzi from the bite of the reduvid bug, it is the 3. Most common parasitic infection in the world and the most common cause of parasitic cardiomyopathy. Typical features include conduction system abnormalities, SA and AV node dysfunction, and RBBB, AF, ventricular tachyarrhythmias, small ventricular aneurysms. Diphtheria. Affects the heart in almost half of cases and is the most common cause of death in patients with this infection. Non-infective. Granulomatous inflammatory disease, sarcoidosis, giant cell myocarditis, hypersensitivity myocarditis, polymyositis, dermatomyositis, collagen vascular disease, peripartum cardiomyopathy, transplant rejection. Toxic. Alcohol, catecholamines, amphetamines, cocaine, chemotherapeutic agents, anthracyclines, trastuzumab, interferon, hydroxychloroquine/chloroquine, drugs of misuse, emetine, anabolic steroids, heavy metals, mercury, lead, occupational exposure, hydrocarbons, arsenicals. Alcohol is the most common toxin implicated in chronic dilated cardiomyopathy, alcoholic cardiomyopathy. 6 4 ounces of pure ethanol, daily for 5 to 10 years, but binge drinking may also be sufficient. Diastolic dysfunction, mild ventricular dilatation and subclinical depression of contractility can be seen before the development of heart failure. AF occurs commonly. Anthracyclines cause characteristic histologic changes of vacuolar degeneration and myofibrillar loss. Trastuzumab cardiotoxicity does not always resolve, and some patients progress to heart failure and death. Cyclophosphamide and ifosfamide cardiotoxicity occur acutely with very high doses. Metabolic, nutritional deficiencies, thiamine, selenium, carnitine, electrolyte deficiencies, calcium, phosphate, magnesium, endocrinopathies, thyroid, pheochromocytoma, diabetes, obesity, hemochromatosis, familial, skeletal and cardiac myopathy, dystrophin-related dystrophy, Duchenne's, Becker's, mitochondrial myopathies, Kearns-Sayre syndrome, arrhythmogenic ventricular dysplasia, hemochromatosis, associated with other systemic diseases, susceptibility to immune-mediated myocarditis. Overlap with restrictive cardiomyopathy. Minimally dilated cardiomyopathy, hemochromatosis, amyloidosis, hypertrophic cardiomyopathy. Idiopathic, miscellaneous, diagnosis, usual blood tests as stated above, low sodium indicates poor prognosis in heart failure. Echocardiography ECG may show tachycardia, nonspecific STT wave changes, poor R wave progression. Echocardiography may show globally dilated hypokinetic heart with low ejection fraction, mitral regurgitation, tricuspid regurgitation, and left ventricular thrombus. Treatment. Is it reversible? If appropriate, bed rest. Use of beta blockers, angiotensin-converting enzyme inhibitors, diuretics, and digoxin. Some have a dramatic response with first two. Anticoagulation, biventricular pacing, intracardiac defibrillator insertion, cardiac transplantation. Mortality is variable, depending on the cause. Restrictive cardiomyopathy. Background. Characterized by reduced or normal diastolic ventricular cavity volume and stiff ventricular myocardium that causes intracavitary pressures to markedly rise with only small amounts of filling volume. Idiopathic restrictive cardiomyopathy is more common in the elderly, and occurs more often in women. Clinical features. Presence with biventricular diastolic failure. Right-sided failure predominates with fatigue, edema, anorexia, exertional dyspnoea and pulmonary edema. Progressive disease may cause hepatomegaly, ascites, and anasarca. An S3 gallop is typically present, but unlike in systolic heart failure or constrictive pericarditis, the apical impulse is forceful. Diagnosis: 2DED shows restrictive ventricular filling, normal ejection fraction, severe biatrial enlargement, and normal wall thickness with increased central venous pressure. Evaluation for a secondary cause is guided by history and physical examination. Amyloidosis. Suggested in patients with neuropathy, proteinuria, and macroglossia. Low QRS voltage on electrocardiography, 10 pounds MV in all precordial leads or 5 pounds MV in all limb leads, despite thick ventricular walls on 2DED, consistent with an infiltrative restrictive cardiomyopathy. Gingival biopsy or an abdominal fat pad ASPI rate can confirm amyloidosis, but endocardial biopsy should be done if the former is non-diagnostic. Sarcoidosis. Suspected in patients with concomitant pulmonary disease. Cardiac involvement can be confirmed by cardiac magnetic resonance imaging, which detects focal myocardial areas of high intensity. Endocardial biopsy is insensitive. Hemochromatosis. Iron overload and storage disorder is the initial signal for its diagnosis in majority of cases. Transferrin saturation and serum ferritin are useful screening tests. Cardiac magnetic resonance imaging can confirm cardiac involvement by demonstrating very low signal intensity from iron deposits. Hereditary hemochromatosis is autosomal recessive, confirmed by genetic testing. Management. Prognosis is generally poor. Treatment is directed towards specific etiologies with additional therapy guided by symptoms, diuretics, beta blockers, calcium channel blockers. Dyspnoea and volume overload are treated with diuretics. Excessive diuresis can lower filling pressures too much, leading to reduced stroke volume, orthostatic hypotension, and syncope, serial urea, electrolytes, and creatinine monitoring. Beta blockers, verapamil, and diltiazem are useful adjuncts to diuretics, enhancing diastolic filling. Pacemakers may be needed for bradyarrhythmias, conduction abnormalities leading to heart blocks. Hypertrophic cardiomyopathy. Background. Characterized by diffuse or focal left ventricular hypertrophy that occurs in the absence of conditions that increase after load. Familial autosomal dominant disease occurs in 50% of patients. Course is benign in most cases, but it can cause significant morbidity, including syncope, arrhythmia, AF may precipitate HF or stroke, ischemia, heart failure, and stroke. Within 10 years of diagnosis, 25% of patients with HOCM with no or mild symptoms will develop debilitating symptoms, 5 to 10% will progress to dilated cardiomyopathy, LVOT is lost. Clinical features. Typically, asymptomatic in childhood and adolescent. Symptoms include angina, dyspnoea, palpitations, fatigue, dizziness, and syncope secondary to diastolic dysfunction, myocardial ischemia, outflow obstruction with or without associated mitral regurgitation, or atrial fibrillation. Maneuvers that decrease preload, Valsalva maneuver, enhance the murmur, and those that augment venous return, leg elevation, diminish the murmur. Most common pattern of hypertrophy is asymmetric septal hypertrophy. A midsystolic murmur caused by left ventricular outflow tract obstruction. Causes of cardiovascular death in patients with HOCM include major, cardiac arrest from ventricular fibrillation, spontaneous sustained ventricular tachycardia, family history of premature sudden death, unexplained syncope, left ventricular diastolic wall thickness superscript 330 mm, blunted increase or decrease in systolic blood pressure on exercise, non-sustained spontaneous ventricular tachycardia, heart failure that has progressed to dilated cardiomyopathy with ejection fraction pound 35% and functional class 2 or 3 symptoms. Possible, atrial fibrillation, myocardial ischemia, left ventricular outflow tract, high-risk gene mutation, intense physical exertion. Not predictive, ventricular arrhythmias inducible by electrophysiologic stimulation, chest pain, dyspnea, moderate or severe mitral regurgitation. Diagnosis. Electrocardiography is typically abnormal, showing increased QRS voltage and abnormalities of the STT waves. Prominent Q waves may simulate a myocardial infarction. In septal hypertrophy, Q waves are seen particularly in the inferolateral leads. T waves are upright in the leads with Q waves, and inverted T waves suggest an alternative diagnosis, i.e., myocardial infarction. If apical hypertrophy is predominant, anterior T waves may be deeply inverted and symmetric. Echocardiography shows increased left ventricular mass, disproportionate hypertrophy, hyperdynamic or preserved ejection fraction, diastolic dysfunction, small left ventricular cavity, systolic anterior movement of the mitral valve, and atrial enlargement. Compared to hypertrophic cardiomyopathy, athlete's heart is more apt to manifest concentric hypertrophy, less marked hypertrophy, wall thickness 15 pounds mm, an enlarged left ventricular cavity, and GT 55 mm and diastolic diameter. In hypertension and Fabry's disease, the phenotypic morphology is typically concentric wall thickening, whereas HOCM is usually asymmetric. Tissue Doppler echocardiography measures velocity of myocardial contraction and relaxation and may allow disease detection before development of hypertrophy, helpful in athletes in which left ventricular hypertrophy may be due to exercise. Exercise echocardiography is useful to unmask label obstruction. Gradients and GT30 mmHg are hemodynamically significant and those and GT50 mmHg are severe. Cardiac magnetic resonance imaging detects focal areas of hypertrophy and fibrosis, adds incremental diagnostic information if hypertrophic cardiomyopathy cannot be differentiated or confirmed from other causes. Management. No major risk factors for sudden cardiac death. Annual screening for risk factors. Asymptomatic, genetic mutations, no phenotypic cardiac features. Annual follow-up, included echocardiography. Reassurance. No empiric medications. Genetic counseling when appropriate. Restriction of vigorous exercise is controversial in the absence of symptoms, family history of sudden death, or identification of a malignant gene unique to the family. Asymptomatic, phenotypic cardiac features but no major risk factors for sudden cardiac death. Annual follow-up includes echocardiography, ambulatory monitoring for ventricular tachycardia, upright exercise stress test for blood pressure response, empiric use of medications, example beta blockers, to delay disease progression or prevent sudden death is unproven but can be considered on an individual basis. Avoidance of vigorous exercise, stable heart failure symptoms, preserved systolic function, use of beta blockers, verapamil, disopyramide, diuretics, judiciously. Permanent pacemaker if needed to allow up titration of medications with negative chronotropic properties. Progressive heart failure symptoms refractory to medications, preserved systolic function, outflow tract obstruction. Septal myomectomy or alcohol septal ablation. Progressive heart failure symptoms refractory to medications, reduced systolic function, no outflow tract obstruction. Use of vasodilators, beta blockers, digoxin, spironolactone. Heart transplantation. Use of intracardiac defibrillator device for ejection fraction pound 35%. One or more of the following major risk factors for sudden cardiac death. Previous cardiac arrest, sustained ventricular tachycardia, ventricular fibrillation. Use of beta blockers. Use of intracardiac defibrillator device. Avoidance of vigorous exercise. Genetic testing and screening. Routine genetic testing in patients with hypertrophic cardiomyopathy is not recommended to predict risk and outcome. Screen the most affected patient in a family with hypertrophic Cardiomyopathy. First-degree relatives of patients with hypertrophic cardiomyopathy, who share the causative mutation should undergo surveillance, echocardiography every 3 to 5 years for adults, and annually. Condition, valvular heart disease. Background. May be categorized as stenotic. Result in pressure overload. Increased afterload results in concentric left ventricular hypertrophy. With progression of the stenosis, diastolic dysfunction occurs, before regurgitant. With progression of the stenosis, diastolic dysfunction occurs, before systolic dysfunction. Regurgitant. Result in volume overload. The left ventricular remodeling pattern is eccentric hypertrophy, a compensatory mechanism that maintains ventricular compliance. Systolic dysfunction ensues with worsening of regurgitation and left ventricular dilatation. Combined, may develop concentric and eccentric hypertrophy, with the dominant lesion determining left ventricular remodeling, clinical presentation, and management. Clinical features. Ventricular remodeling leads to the major clinical outcomes. Dyspnoea with exertion is the most common symptom. Right-sided valve lesions more commonly are associated with systemic venous congestion, resulting in lower extremity edema, abdominal distension, or ascites, may occur with left-sided lesions if with LV systolic dysfunction or pulmonary hypertension. Aortic valve lesions, either stenosis or regurgitation, may also be associated with exertional symptoms of angina, due to reduced coronary flow reserve through the hypertrophied myocardium, causing subendocardial ischemia, or presyncope or syncope, due to reduced cardiac output reserve. Mitral valve stenosis and regurgitation are both strongly associated with a higher incidence of atrial fibrillation, causing palpitations, fatigue, and acute onset dyspnoea. Heart murmur is the hallmark of valvular dysfunction on auscultation. Valvular and other cardiac lesions and their associated examination findings. Other cardiac lesions and their associated examination findings. Cardiac condition. Aortic stenosis. Valvular. Characteristic murmur. Mid-systolic, crescendo decrescendo endo. Location. RUSB. Radiation. Right clavicular. Associated findings. Enlarged, non-displaced. Apical impulse. S4, bicuspid. Valve without calcification will have systolic ejection click, followed by murmur. Severity and pitfalls. Severe aortic stenosis may include decreased A2, high-pitched, late peaking, murmur, diminished and delayed carotid, upstroke, radiation of murmur down the descending thoracic aorta, may mimic mitral regurgitation. Asterisk aortic regurgitation, diastolic, decrescendo endo, LLSB, valvar, or RLSB, none. Enlarged, displaced apical impulse, S3 or S4, increased pulse pressure, bounding carotid and peripheral pulse. Acute, severe regurgitation murmur may be masked by tachycardia. Short duration of murmur. Severity in chronic regurgitation is difficult to assess by murmur. Asterisk mitral stenosis, diastolic, low-pitched, apex, heard best in left lateral decubitus position, none. Opening snap after S2 if leaflets mobile, irregular pulse if atrial fibrillation present. Interval between S2 and opening snap is short. In severe mitral stenosis, intensity of murmur correlates with transvalvar gradient. P2 may be low pulmonary hypertension present. Asterisk mitral regurgitation, systolic, hollow, or late systolic, apex, to axilla or back, occasionally anteriorly to precordium. Mitral valve, systolic dick in, mitral valve, prolapse, apical impulse, hyperdynamic, and may be displaced if dilated left ventricle, mitral valve, prolapse, valsalva, mano uver, moves onset of Murmur closer to S1, hand grip, increases. Murmur, intensity. Acute, severe regurgitation may have soft or no holosystolic murmur, mitral inflow rumble, S3. Tricuspid stenosis. Diastolic, low-pitched, decrescendo endo, increased intensity during inspiration. LLSB. Non-radiating. Elevated central venous pressure with prominent A wave, signs of venous congestion, hepatomegaly, ascites, edema. Low-pitched frequency may be difficult to auscultate, especially at higher heart rate. Tricuspid regurgitation. Holosystolic, LLSB, LUSB. Merged and prominent C and V waves in jugular venous pulse, murmur increases during inspiration. Right ventricular impulse below sternum pulsatile, enlarged liver and possible ascites. May be higher pitched of associated with severe pulmonary hypertension, pulmonary stenosis, systolic, crescendo decrescendo endo. LUSB. Left ventricle. Pulmonic ejection click after S1, diminishes with inspiration. Increased intensity of murmur with late peaking. Pulmonary regurgitation. Diastolic, decrescendo endo. LLSB, none. Loud P2 if pulmonary hypertension present. Murmur may be minimal or absent if severe due to minimal difference in pulmonary artery and right ventricular diastolic pressure. Asterisk innocent flow murmur, mid-systolic, grade 1/6 or 2/6 in intensity. RUSB, none. Normal intensity of A2, no radiation to left clavicle. May be present in conditions with increased flow, e.g. pregnancy, fever. Anemia. Hyperthyroidism. Hypertrophic obstructive cardiomyopathy. Systolic, crescendo decrescendo endo. LLSB, none. Enlarged. Hyperdynamic. Apical impulse. Bifid carotid. Impulse with delay. Increased intensity during Valsalva maneuver or with squatting to standing. Harsh murmur with increased intensity. Murmur may not be present in non-obstructive hypertrophic cardiomyopathy. Atrial septal defect. Systolic, crescendo decrescendo endo. RUSB, none. Fixed, split S2, right ventricular heave rarely tricuspid inflow murmur. May be associated with pulmonary hypertension including increased intensity of P2 heart sound, pulmonary valve regurgitation, ventricular, septal defect, holosystolic, LLSB, none. Murmur, palpable thrill, murmur increase with hand grip, murmur increase with hand grip, decreases with amyl nitrite. Murmur, intensity and duration decreases as pulmonary hypertension develops, Eisenmenger syndrome, cyanosis if Eisenmenger syndrome develops. Diagnosis, transthoracic echocardiography. Indicated in symptomatic patients, those with a systolic murmur grade 3/6 or greater, and in those with any continuous murmur, or diastolic murmur, transoesophageal echocardiography. Indicated for those with severe mitral valve disease, prosthetic valves, and infective endocarditis, or in patients in whom transthoracic imaging is not informative. Valvular lesions are usually followed up every 6 to 12 months by echocardiography depending on the severity of the lesion, every 6 months for severe aortic or mitral regurgitation to monitor for the development of asymptomatic left ventricular dysfunction. Electrocardiography, may be performed to evaluate for adverse effects of valvular lesions, such as left ventricular hypertrophy, ischemia, or atrial fibrillation, but is insensitive for evaluation of ventricular function. Brain natriuretic peptide, BNP, associated with the presence and severity of symptoms, dyspnoea, in various heart conditions, including aortic stenosis and mitral regurgitation, and has been found to have adverse prognostic implications if elevated, most useful in ruling out other conditions. Exercise testing may be helpful in prognostication such as exercise capacity and blood pressure response. Cardiac catheterization. Not routinely performed unless coronary artery disease is suspected, and the possibility of coronary artery bypass graft is entertained. Management. Timing of intervention for valvular heart diseases is primarily based on the presence of cardiopulmonary symptoms attributable to the lesion or evidence of adverse hemodynamic consequences, particularly ventricular dilatation, or systolic dysfunction. When symptoms develop, intervention is indicated regardless of ventricular systolic function because of a significantly increased risk of adverse outcomes. No medical intervention has been shown to improve the long-term natural history of these progressive conditions. Surgical valve repair or replacement, indicated in severe valve dysfunction with symptoms or abnormal ventricular function, is the only definitive intervention for valvular heart disease. Indications for intervention for valvular heart conditions. Valve lesion. Aortic stenosis. Indications to intervene. Symptoms. LVEF and LT 50%. Moderate stenosis at other cardiac surgery. Abnormal blood pressure. Response. Systolic blood pressure. During exercise. Rapidly progressive. Stenosis. Intervention. Aortic valve replacement. Aortic regurgitation. Symptoms LVEF and LT 50% LV dilatation, end systolic dimension and GT 55 mm or end diastolic dimension and GT 75 mm. Aortic valve replacement with ascending aorta graft replacement if enlarged. Mitral stenosis. Symptoms pulmonary hypertension, PA systolic pressure greater than or equal to 50 mmHg at rest or greater than or equal to 60 mmHg during exercise. Percutaneous balloon. Valvotomy, if anatomy favorable by echocardiography, with less than moderate mitral regurgitation and no left atrial thrombus. Mitral regurgitation. Symptoms. LVEF and LT 60%, LV and systolic diameter, and GT 40 mm. Pulmonary hypertension. PA systolic pressure greater than or equal to 50 mmHg at rest or greater than or equal to 60 mm. Hg during exercise. New onset atrial fibrillation. Mitral valve repair if anatomy favorable, presence of annular dilation, mitral leaflets. Prolapse, myxomatous. Changes without calcification or stenosis, mitral valve replacement. Tricuspid regurgitation. Refractory right-sided heart failure, right ventricular enlargement, systolic dysfunction, moderate or severe regurgitation at time of mitral valve surgery. Tricuspid valve repair if anatomy favorable, tricuspid valve replacement, bioprosthetic. Condition, aortic diseases. Thoracic aortic aneurysm. Background. Can involve the aortic root, ascending aorta, aortic arch, or descending aorta, the first two segments being most affected. May be due to cystic medial degeneration associated with aging and hypertension, most common, atherosclerosis, most of descending aortic aneurysm, bicuspid aortic valve, aortic root and ascending aorta, connective tissue disorders, example Marfan syndrome, vasculitis, example Takayasu arteritis, giant cell arteritis, infection, example syphilis, trauma. Clinical features. Typically, asymptomatic, and mostly an incidental finding, example widened mediastinum on chest radiography. May present with compressive symptoms, example hoarseness, stridor, shortness of breath, cough, dysphagia, and back pain. Rupture is the leading cause of death. Risk factors for rupture include a diameter and GT 5 cm, rapid expansion, and pregnancy. Diagnosis. Transoesophageal echocardiography gives better visualization of the aorta than transthoracic echocardiography, but the former is invasive. Computed tomography and magnetic resonance imaging give good visualization of the entire aorta and side branches, with the former disadvantaged by radiation exposure. Management. Asymptomatic non-traumatic thoracic aortic aneurysm. Non-urgent computed tomography aortogram or echocardiogram. Refer to a vascular surgeon for elective repair in the following situations. Diameter and GT 6 cm, or NGT 4.5 cm in Marfan syndrome. Rapid growth, that is, NGT 0.5 cm/year. Cardiac valve surgery is considered. Surveillance every 6 to 12 months if the diameter is NGT 4.5 cm, concomitantly addressing potential risk factors, i.e., use of stains, antihypertensive medication, and beta blockers. Symptomatic non-traumatic thoracic aortic aneurysm. See acute aortic syndromes. Acute thoracic aortic syndromes. Background. Includes aortic dissection, intramural hematoma, penetrating atherosclerotic ulcer, and trauma-induced aortic rupture. Risk factors include hypertension, most significant, atherosclerosis and smoking. Stanford classification. Type A dissections originate within the ascending aorta or arch. Type B dissections originate distal to the left subclavian artery. Clinical features. Aortic chest pain is classically described as severe tearing pain radiating to the anterior chest, back, abdomen, or jaw. Blood pressure may be noticeably high. Other physical examination findings include a faint aortic regurgitation murmur, paradoxical pulse, and asymmetric blood pressure in the upper extremities. Diagnosis. Chest radiography may show widening of the mediastinum and a pleural effusion, leaking aneurysm. Electrocardiography is non-diagnostic but may show inferior wall myocardial infarction. The choice of imaging modality depends on the patient's hemodynamic status. For hemodynamically unstable patients, transoesophageal echocardiography at bedside is preferred over computed tomography or magnetic resonance imaging due to the potential deterioration of the patient during transit. For hemodynamically stable patients, computed tomography or magnetic resonance imaging is preferred. Management. Management always starts with hemodynamic assessment. If stable or not in shock, lower the blood pressure to a level that does not compromise organ perfusion and heart rate, and LT 70 bpm, with intravenous beta blockers, sodium nitroprusside, labetalol, enalapril, hydralazine, or nicardipine. All type A and complicated, persistent pain, uncontrollable or suboptimally controlled high blood pressure, rapid aneurysmal expansion, aneurysmal rupture, or malperfusion syndrome, type B aortic dissecting aneurysms require emergency surgery. Uncomplicated type B dissecting aortic aneurysms is treated medically with judicious blood pressure control. Back, abdominal aortic aneurysm. Background. Affects 4 to 7% of men and 1 to 2% of women and GT 65 years. Known risk factors are advancing age, male gender, smoking, family history, atherosclerosis, hypertension, and hypercholesterolemia. The average expansion of an aneurysm and LT 5.5 cm is around 2 to 3 mm per year. Aneurysms and GT 5.5 cm in men and GT 5.0 cm in women are at a significant risk of rupture. Clinical features. Most often an incidental finding during physical examination, pulsating abdominal mass, or imaging for a different indication. May present with compressive symptoms. Diagnosis. Ultrasonography is the imaging modality of choice for surveillance. No formal surveillance protocol in Australia. The suggested surveillance interval is every 2 years if 3.0 to 3.9 centimeters. Yearly if 4.0 to 4.5 centimeters. Every 6 months if 4.6 to 5.0 centimeters. Every 3 months if NGT 5.0 cm. Computed tomography angiography is the imaging of choice if surgical repair is considered. Digital subtraction angiography is reserved for therapeutic purpose and is used during endovascular aneurysm repair for proper stent positioning. Management. Aggressive risk factor management is advocated, i.e., smoking cessation and use of a statin, antiplatelet and antihypertensive medications. Indications for surgical repair: male with an aneurysm diameter of NGT 5.5 cm. Female with an aneurysm diameter of NGT 5.0 cm. Aneurysmal growth of NGT 1.0 cm per year. Symptomatic aneurysm. Surgical repair is discussed in surgery, open versus endovascular aneurysm repair. Ruptured abdominal aortic aneurysm. Background: high mortality rate, 80 to 90%, although most abdominal aortic aneurysm do not rupture. Clinical features: abdominal signs, hypovolemic shock. Rupture directly into the peritoneal cavity is rapidly fatal, while rupture in the retroperitoneum can be temporized. Diagnosis: requires a high index of suspicion. Management: protect the hemodynamics. Emergency surgical repair, endovascular aneurysm repair is preferred over open repair.